Welcome to Community Conversations. I'm Randi Oster, and this is Jill Wruble. And today we are very excited to talk to you about healthcare and what you can do to improve it for yourselves. We come from it from two perspectives. I come from it as a patient and as a loving mother and as a wife who has a husband with a pre-existing condition. And Jill comes from it from the perspective of a physician. And you work as a physician in what area?
I'm a radiologist. I work at VA Connecticut. I teach radiology residents at Yale and at UConn. And I've practiced in a number of different settings. I was in the military. I trained in the military, so I have exposure to that system. Private practice, and now the federal government, and patients of different ages with different types of illnesses and different types of communities.
Great.
So I think it's fairly broad.
Jill, I am so thrilled to be talking with you today on so many levels from a perspective of wanting to improve the system. I'll just share with you a little bit about what happened in my case. And you talked about the military background. I am an engineer. I worked in aerospace in the military, working on programs including the stealth fighter, and was the woman who led the team in the design of the electronic combat system. What happens when you have those complex systems in top secret programs, we learn about communication, we learn about safety, we learn about making sure that the missions are accomplished. And here's what happened to me. My son has Crohn's disease. He needed an operation. I had never been in a hospital except to have him. And the next thing you know is he's admitted. And with my background, as I'm looking at what I would call a frantic floor of people running in and running out, and me having to repeat the same things over and over again. No, he's not allergic to anything. No, he didn't eat, whatever. And I didn't know who this person was and who that person was. It was very quick that I said, I think there's some process issues here. And my journey started that day. My journey started with me saying, how am I going to help them improve? Because I can see some improvements. And from that, my son had complications from his surgery. My notes that I took ended up becoming a book, which I wrote, which I know you have also read. And I decided, and I learned, even after I wrote the book, the issues that I had were not unique to my son or his doctor or that hospital. It's a systematic issue in this country. My guess is, from your background with some of the military experience, you too probably have a little bit of a sense that it's bigger than what you've experienced. You and I both care about what they call right care. And right care is not too much care or too little care, but what's right for each of us. And so I'm really interested in how this has become a passion for you.
Sure. I initially came to this realization that there were problems with the way we were practicing because of changes in the practice of radiology over the last decade or so. Utilization of imaging has increased, and the resolution of the images we acquire is unprecedented. It's magnificent. It's spectacular. So we can see things that we could never see before. And we feel compelled then to treat them. And many of them are unrelated to the issue that brought them to the doctor or brought them to imaging. The assumption is that because they're there must be threatening, or because we can't be certain that they're not threatening, they must be treated. And sometimes that treatment causes more harm than benefit.
So when you talk about imaging, are you talking about CAT scans and MRIs? So those kind of...
CAT scans, MRIs, ultrasounds.
Okay. Just from my perspective, my son, every time he was brought into the emergency room, which was 6 times in a period of 5 weeks, he kept having these seizures, they would always give him a CAT scan. And each time the CAT scan showed nothing. By the time it was his 4th time in the emergency room, and they go, oh, CAT scan. I was like, it's not going to show anything. And I said, no. I learned to question. And the doctor said to me, well, did you know one CAT scan is like, I don't even know, 500 x-rays? I didn't know that.
Yeah, there is concern about radiation. CAT scans have a reasonable amount of radiation. There are times when a CAT scan is appropriate. It's the best study for an acute pathology following surgery, but repeating them again and again, of course, isn't necessarily a great idea. The point that I wanted to make is that there were unexpected findings on studies ordered for other reasons. Incidental findings. Now we call them incidental omis. Tumors that are found on scans that are performed for unrelated reasons. Almost always they result in a cascade of testing and treatment, which may not be beneficial at all and sometimes is harmful. It takes time, it causes anxiety, it costs money, and sometimes the intervention are harmful. I gave a TED talk not long ago about incidental omis, and I started with a little video clip of Bodie Miller crashing at the World Cup a couple weeks before the last Olympics, and said, and Bodie walked away. The guy got up and walked away from this horrific fall. But I said, imagine if he'd gone to the emergency room. He would have had he had a little bit of abdominal pain. He would have had a CT scan, and they would have said, oh, that your spleen's fine. There's no trauma. But because he was an older athlete, you have a whole bunch of incidental findings, the kinds of things we see typically in a middle-aged person who comes into the ER after a car accident or a fall off their bike. You have a little nodule on your kidney. You have a little nodule on your liver. You have a little nodule on your pancreas. And you're going to need more studies. So we're going to work up your adrenal gland with an MRI, and we're going to work up with your kidney with a special CT scan. And by the way, when we did that special CT scan of your kidney, which was of the abdomen, it included the lower part of the chest. We saw a little lung nodule in the lower part of the chest. So now we're going to do a chest CT. Now that nodule is probably nothing, but we'll probably do follow-ups. But there was something at the upper margin of that CT scan in your thyroid. So now we need to do a thyroid ultrasound, and we're probably going to need a biopsy. And you know what? That was a low-grade cancer, and maybe you need to have your thyroid removed. And by the time he's done, Bodie Miller, he's missed the games, right? But if he didn't go to the ER, he would have been the most decorated skier in American history because he would have medaled, which in fact is what happened. So that's what happens. People end up being imaged. They may or may not, very infrequently, won't have an abnormality at the site of concern, but they wind up becoming a part of the imaging vortex, which is really hard to dig out of. Technology enables us to see much more. When I was a young radiologist, one abdominal CAT scan had about 50 images such as this. Now one scan has 300 to 3,000 much finer images. I review more images on one patient's scan than I did in 3 full days of work back then. Technology enables us to see more, and that's a benefit, but that, less obviously, is the problem. And it's compounded by the fact that it's better to be safe than sorry. No one wants to take a chance. What if the possibility that that tiny renal thing is a cancer? It's a remote possibility. Maybe it's depending upon the patient's age and the appearance of the lesion, maybe it's a 0.02% chance of malignancy, but people say, I don't want to worry about it. Right. Because we don't like uncertainty. I'd rather undergo an intervention now than live with the possibility that in 15 years it might be something bad. Right.
There are some trade-offs. When you talked about the thyroid, I've read some studies now where they have said that sometimes these precancerous nodules either can take a long time or they can get better. So we always say, well, what's the risk of doing this or what's the benefit? What we need to be asking is what's the risk and what's the harm?
Right.
What's the harm?
I think that's true. I just noticed anecdotally that there were an awful lot of these incidental findings, and it was because we were imaging more and because the resolution was better. Right. And we were chasing them in many instances in which it could not have been beneficial. Because many of our patients at the VA are very elderly, and these things are so low risk, and sometimes the patients are very ill with an alternate disease, yet we're following a finding with extremely low risk. I'll give you an example. Not long ago, I was asked by CT techs to come to consent a patient for a CT scan because he was about to get contrast dye, and he had a history of contrast allergy. I learned that, one, his contrast reaction was life-threatening anaphylaxis.
Oh.
2, he was 85 years old.
Okay.
3, he had end-stage emphysema. 4, he had lung cancer, and that lung cancer was very advanced. It had spread already to his liver. He had terminal cancer. But we were doing that CT scan
Yeah.
to follow up a benign renal cyst.
Oh.
Right?
Okay.
So that's the kind of, and that's an extreme example.
That's an extreme example.
It comes about because of, the person who, the primary care doc, became aware of the renal cyst before the patient developed the lung cancer, sent the patient to a urologist who wasn't aware of the lung cancer,
Right.
ordered that, or maybe it even preceded the lung cancer,
Okay.
ordered that study. The patient came for a follow-up without anyone having realized that he now had a different problem.
Mm-hmm.
So I don't mean to suggest that that's the way we practice at the VA or that that's typical,
Right.
but the idea that we're following things that are trivial
Right.
or that in a given patient are almost certainly irrelevant,
Right.
that's common.
Right.
And in radiology, it's exacerbated by the fact that there are penalties for misses, all right, and no penalties for overcalling. No penalties for including in your report tiny renal lesion, probably nothing but might be cancer. There's
Okay.
no penalty for that, but that compels
Right.
the workup. It starts this cascade of testing,
Right.
anxiety, interventions, some of which are harmful. So that's what first brought me to this whole issue. When I observed this, I wanted to find out whether it was just simply my observation.
Right.
So I started reading everything I could find about whether there was medical evidence to suggest that these were findings in certain organs that could be ignored
Right.
or really required follow-up. I realized that that information is evolving. It's really incomplete. It's inconclusive. So that patients often have to make a value judgment. They have to weigh the benefits and the harms with incomplete data. These are trade-offs. The decision a patient will make is often based upon their personal values. So then I became interested in all the things that affect that.
Right.
So there's bioethics. Are we obligated to report all of these findings? Maybe they're trivial.
Right.
Maybe they're so trivial that they're like one of the zillions of freckles on my forearm that the primary care doc doesn't mention when he does a physical exam.
Right.
Is it my obligation to make sure that I mention everything? Different radiologists have different opinions about that. So there are ethical and bioethical issues. There's psychology. There's the tolerance of uncertainty. I read about this from as many perspectives as I could. There's some people's inclination to be skeptical and others' inclination to be deferential.
Right.
I felt that I could make a contribution by striking a balance, by tending to describe findings in a manner that decreases alarm. Even with incomplete data, a lot of it can be addressed by the language that the radiologist chooses to use.
Because we're listening as patients, we're listening, and there are a couple of things that you talked about that I noticed, and that was the aha for me. Everyone works on their part of our system, okay? And you described it. You have this doctor looking at this and this doctor looking at that, and then what occurred to me is that the system was me and my loved ones, and then there's the second piece of that. We were the only ones looking at the whole thing,
Right.
and also looking at it over the future of time. And I
What's
think-
ultimately in the patient's best interest.
right? the
Nobody
long-
considers that.
Right. Oh,
Yes.
thank you for saying.
Okay.
Wait, I want to just finish this.
Yeah.
So this was such an aha. What I realized is each doctor takes care of their station stop, and then if there are problems because of the treatment at that station stop, it's when you get to the next station stop, they deal with that. But the understanding that at this station stop, there's a decision that the patient should make because there's a choice, and you talked about it. Their preferences, their values, their goals might choose them not to go on this path. They might take that path. In some of the cases where you've given some examples, the system has been designed in a way that they are rewarded for what is not necessarily right for the patient.
Right.
What I have learned and what I'm so thrilled about listening to you is that's a communication between us, that we need to understand what are the risks and the harm, and then we need to say, you know what, this is so slow growing, I'm willing to take that one, or I'm not willing to take that one.
Right.
That's what I want to change in the system, that when we talk about right care is we're at that station stop together. At this point, the patient has to talk to all of the different people. They're like, right? Okay. But each of those people has to have that same conversation with us. Eventually, I would love that there was a systems engineer, but it's probably a primary care physician that is actually helping you navigate.
Right.
Okay. But we're not quite there yet.
So there are places where that happens. One of the reasons why this became apparent to me is because my dad is a primary care doc. He's now 85, but I spent a lot of time in his office at Family Doctor when I was growing up, and he practiced that kind of medicine. Well, he's a DO, and it's part of the philosophy of osteopathic medicine to look at things holistically. And to some degree, it was more typical of old-time practice.
Okay.
There are places where there is, at Mayo, for example, and I believe this is true at the Cleveland Clinic, for example, we once lived in Minnesota, and my husband was a corporate officer there, and he was invited to Mayo for one of these check-in 2-day physical exams. And one person, I think he was an internist, served as that person who made the referrals to each of the specialists after a thorough discussion with my husband about what was appropriate, sat down with everyone, and then reported back to my husband the conclusion. So I think there are places where that happens.
Right.
And increasingly, there is a recognition of the need for a multidisciplinary consult. But I agree, care is fractionated. It's very difficult for a primary who's incredibly busy anyway and is overwhelmed with the documents they need to fill out to contact each specialist.
Right.
It's very, very easy to lose sight of anything beyond one's task or subspecialty. And I'll give you a very poignant recent example from my own experience. So my husband became paralyzed on Memorial Day weekend, completely out of the blue. We were on vacation, a family reunion, and on Saturday he played 2 hours of tennis. On Sunday he developed back pain, and by Monday night he was paralyzed. We were out of town. We were in Vermont. He spent a couple of weeks at UVM Medical Center before he was transferred to a neurologic rehab in Boston. After a week there, he developed a complication. Actually, it was a false alarm, but it caused him to be emergently transferred to Mass General for a workup for a serious infection, something called septic shock, which could be life-threatening. He had no such thing. He did not have an infection.
He didn't have an infection?
No, he did not have an infection.
Okay.
He had a slight dip in his blood pressure, which is something that people with a recent spinal cord injury often have. They have labile blood pressure, and that dip in blood pressure and a borderline elevated temperature prompted a resident to insist that he be emergently transferred to Mass General. And at Mass General, they began a workup of a neurologic problem, completely disregarding the fact that he had been transferred for an apparent overwhelming life-threatening infection. He was confused, and it may have been the narcotics he had been on, it may have been the electrolyte abnormality that was the result of the spinal cord injury, it might have been the recovering from a urinary tract infection, it might have been sleeplessness because he had been in unbelievable pain as a result of bleeding, which was prompted by the therapy for his back pain. So there were a whole bunch of reasons for his confusion, but they started this aggressive workup at Mass General for his confusion.
So confusion was what they were dealing with.
He was admitted to rule out infection. He had no infection. They didn't say he has no infection, go back to Spalding. They started another workup without talking to us at all. And they said, he must have emboli. He must have something that's causing little pieces of clot to be going through his circulatory system into his brain. And they began an aggressive workup to exclude that. So they wanted a complex x-ray of his teeth, the panorex, to make sure he didn't have a dental abscess. Well, I looked in his mouth, and he didn't have a dental abscess. And he hadn't been complaining of dental pain. And all they needed to do was take a light and look in his mouth.
Okay, I just have to take a second here, right? Because that was how many times did I ever experience, like, something obvious that you could do, like touch the patient.
Right. You might consider touching the patient. That's another story. But it's a long...
I don't mean to laugh, but
No.
I just, my heart's with you.
There's more. So we got to the emergency room at Mass General on a Friday night. About noon the next day, a neurologist came in with his very harsh, matter-of-fact announcement that my husband had several horrible brain insults. But he just mentioned matter-of-factly as though he was ordering his latte at Starbucks.
Was he standing up or sitting down?
He was standing, and he didn't barely looked at me or my husband. He barely introduced himself. He didn't address my husband by his name. He put my husband on display in a bunch of residents, asking him questions he knew he wouldn't be able to answer. My husband's a brilliant attorney. Poking at him, can you feel this, can you feel that, covering his eyes, to just demonstrate how impaired he was, and taking on this mission of searching for emboli, completely disregarding
who he is.
But beyond that...
Well, who he is, I mean...
Right, his person.
His person. I mean, not who he is professionally, his person.
The lack of regard, the disregard, the inhumanity of it was a most painful medical experience. It was anguishing. You know, as a physician and as someone who grew up in a medical family, I've been exposed and have someone who's worked in the Army and in private practice and in the government. I have seen a lot of different things. I had never seen anything as anguishing as the disregard with which my husband was being treated. But separate from that, my husband's now a new paraplegic. Oh. He's densely paralyzed from here down. And people with that condition are more likely to have a bad outcome as a result of complications of paraplegia. And that includes preventing urinary tract infections, right, preventing skin breakdown, preventing pneumonia, and preventing blood clots in legs. All the while that they are passionately pursuing emboli, they are completely disregarding everything. They're not turning him. They're not using careful technique when they catheterize him to prevent urinary tract infections. They're not catheterizing him on schedule. They're not making sure that he's taking deep breaths, completely disregarding the things that are really likely to shorten his life. And in fact, he did suffer complications that have persistent ramifications for that reason.
Right.
So I think that the point to losing track of the big picture is something that is so harmful in so many ways. It doesn't place the patient's overall well-being first.
Right.
It's wasteful. I mean, if you want to be, that's a huge problem too, right, that most people individually don't care about. But the misutilization of resources prevents us from putting resources towards necessary care. Now that I'm the wife of a seriously ill patient, I see it with a somewhat different perspective. I think I saw it previously with the empathy of a patient, and also some sense of outrage.
I can't even imagine. But what I do want to talk a little bit about, because we are here to talk about Rightcare. Our voice matters. Our intuition counts. I was speaking to some doctors last week, and they said, you know what? If we let the patient talk, they can sometimes self-diagnose themselves. Now, I'm not saying with something as complicated as what your husband has, but one of the challenges that the medical community has is they're not even given the time to meet with us. The average appointment is 15 minutes.
Right.
Knowing of what you've said, your preferences, your values, and your goals matter, and that can change the course of your care. Change it to even maybe being less care, which is better care for you at that point. I believe that everyone is trying their best to do what's right. And one of the premises of quality programs, right, that we came through in aerospace was don't blame the people when there's a mistake. Look at the process, fix the process, and you will fix the system.
Yeah. What we're dealing with is worse than the illness.
So here's my message. You're not alone. I can tell you there are the people at the Rightcare Alliance, all those people who are listening today that we're pulling together to change the system. The system, it's a prescription for depression, okay? Oh my goodness. It is not designed to give you that hug. There is no hug coming to you. And it's designed to, okay. And we didn't talk about this, but financially, one of the leading causes of bankruptcy in this country is medical costs. Those of us that can still find the strength to unite, we're going to be there together. You're getting involved in Rightcare as a physician. I'm involved from the patient side, and anyone else who might ever want to get involved in becoming a member of Rightcare. It's the Rightcare Alliance. You can just Google it and join. As we all look to improve the healthcare system, it's going to take each of us. So I want to thank you for your time today.
Thank you.
And for your story.
Thank you.
And I'll share this. When I wrote my book, I said, I want my book obsolete in 10 years. I have 8 years to go. I want your story to be obsolete in the same, you got 8 years. We're on the team together.
That would be miraculous.
I don't know if we'll
That
do
would
it.
be miraculous.
That's it. So,
And I'll say this, the people I've met through Rightcare and the Related Lounge Institute have been from all walks of life, and it has really been very enlightening and I think effective to come at this from different perspectives.
right, different perspectives, and we will find the solutions.
Yeah,
So
I hope you're right.
I want to thank you for joining Randi Oster and Jill Wruble in this community conversation. Our voice matters. Our intuition counts.
For objecting to objectionable things. I became persona non grata. What we're dealing with is worse than the illness.
So here's my message. You're not alone. I can tell you there are the people at the Rightcare Alliance that we're pulling together to change the system